Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. I'm Dr. Roger Henderson. I'm a GP and I also co-host the GP Notebook study groups. Now you can find us on all major podcast platforms, including Spotify, Apple and Google Podcasts, so do please follow us to receive notifications about new episodes, and if you like what you hear, do please consider leaving a review to help other listeners find us. It really does help. You can also follow us on Twitter at GPnotebook, and you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, in this episode, we'll be discussing acute pancreatitis, an inflammatory disorder of the pancreas characterized by autodigestion of pancreatic tissue due to premature activation of pancreatic enzymes. Now, it's typically a reversible process, but it may become life-threatening if systemic complications or pancreatic necrosis occur. Acute pancreatitis is one of the most common diseases of the gastrointestinal tract that leads to hospital admission, and the incidence in the UK is of the order of 56 patients per 100,000 per year, with about 50% of cases being caused by gallstones, 25% by alcohol, and 25% by other factors. But the two most prevalent causes remain gallstones and chronic alcohol use. Now, gallstone pancreatitis is more common in women over the age of 60, especially among people with microlithiasis, whereas alcoholic pancreatitis is seen more frequently in men. Gallstone-induced pancreatitis, therefore, also known as biliary pancreatitis, occurs when gallstones cause inflammation and edema of the ducts, causing a degree of flow restriction and backflow of activated enzymes into the pancreas. This results in increased intrapancreatic ductal pressure and subsequent acinar cell injury. Small stones or even biliary sludge can trigger this inflammatory cascade. It does not need to be linked to large stones. Alcohol-induced pancreatitis is dose-dependent and more common in people drinking more than 50 to 80 grams of alcohol a daily, about a bottle of wine, over several years. Now, what alcohol does is it increases zymogen secretion whilst decreasing fluid and bicarbonate output. This increases the protein concentration in pancreatic secretions and promotes ductal obstruction and acinar injury. It also directly sensitizes acinar cells to cholecystokinin-induced enzyme secretion. And although our patients with alcohol-induced pancreatitis will present acutely, the underlying pathology is caused by chronic exposure to alcohol and is usually seen after a period of binge drinking against a background of chronic alcohol misuse, to the point that people who don't have a long previous history of excessive alcohol intake are very unlikely to present with alcohol-induced acute pancreatitis. There are some less common causes, and these include hypertriglyceridemia, often seen in poorly controlled diabetes or familial lipid disorders. There may be drug-induced pancreatitis, and some of the implicated drugs here include corticosteroids, thiazides, valproic acid, and azathioprine. There may be a post-ERCP pancreatitis, which occurs in up to 10% of ERCP procedures, which is not insignificant. Blunt abdominal injury or post-surgical trauma may be triggers, as may infections such as mumps, Coxsackie virus, HIV, and CMV. Autoimmune pancreatitis and genetic mutations may very occasionally trigger acute pancreatitis. And finally, idiopathic pancreatitis may and does occur where there is no clear etiology ever identified despite extensive evaluation. Now, the exact mechanism by which pancreatitis occurs is still slightly unclear, but it's thought to involve premature activation of digestive enzymes, especially trypsinogen to trypsin, within the pancreatic acinar cells. Now, this then leads to autodigestion, cellular injury and inflammation, and recruitment of neutrophils and macrophages, which then in turn causes vascular leakage and interstitial edema, then necrosis of pancreatic parenchyma, and a systemic inflammatory response syndrome. If this becomes more severe, this may then progress to multi-organ dysfunction syndrome and full pancreatic necrosis, particularly in the setting of infected necrosis. Now, in my experience, patients typically present with severe, constant upper abdominal pain that's usually sudden in onset and often radiating to the back. And in about 4 out of 5 of these patients, there's associated nausea and vomiting that's sometimes intractable. The severe pain is typically worsened by lying flat and relieved by leaning forwards, a classical finding in my experience too. Now, a really important point here to remember is that you can confirm a diagnosis of acute pancreatitis if at least 2 of these 3 criteria are met. 1. Upper severe abdominal pain, epigastric or left upper quadrant. 2. Elevated serum lipase or amylase levels, by which I mean at least 3 times the upper limit of normal. And 3. Characteristic findings on abdominal imaging, such as CT, MRCP, or ultrasound. But do remember, though, that patients with diabetes have higher median lipase levels and so may need a higher diagnostic threshold, maybe even 3 to 5 times the upper limit of normal. And in addition, the accuracy of tests typically decreases with time from the onset of pancreatitis symptoms. Now, physical findings do vary according to the severity of the pancreatitis present. And I've seen this ranging from a generally well patient to very seriously ill patients with abnormal vital signs such as tachycardia and fever. There may be epigastric tenderness, abdominal distension with reduced bowel sounds, and signs of hypovolemia such as tachycardia or hypotension. Now, interestingly, do remember that because of the anatomical location of the pancreas, any guarding that you find on abdominal palpation in someone with acute pancreatitis may be less intense than you expect for the degree of pain that the patient is experiencing. Now, I've only seen this once in my career, but severe cases with hemorrhagic pancreatitis due to pancreatic necrosis may exhibit either Cullen's sign, which is a bluish periumbilical discoloration, or Gray-Turner's sign, which is bilateral flank ecchymoses. Now, these are signs of retroperitoneal hemorrhage and unfortunately indicate a poor prognosis. If we turn to imaging now, don't use abdominal imaging to confirm a diagnosis of acute pancreatitis unless there's diagnostic uncertainty or there's a failure to respond to treatment. But having said that, all patients with acute pancreatitis do need a transabdominal ultrasound to confirm or exclude cholelithiasis. Ultrasound sensitivity in detecting pancreatitis can be as high as 90%, but this can be limited by obesity and bowel gas and is operator dependent. Most patients don't need contrast-enhanced CT scans, as the diagnosis is usually based on clinical presentation and serum lipase and amylase levels. So a CT for the purpose of assessing disease severity is not usually performed until 72 to 96 hours after the onset of symptoms, by which time the complete extent of any necrosis should be visible. Endoscopic ultrasound, or MRCP, can be done in preference to a CT scan to screen for choledocholithiasis, and if it's highly suspected in the absence of cholangitis and or jaundice, that's when it's usually looked at. An endoscopic ultrasound is also indicated in patients considered to have idiopathic acute pancreatitis to exclude things like strictures, malignancy, occult biliary microlithiasis, and chronic pancreatitis. Now, when we're looking to sort of define the severity of acute pancreatitis, the revised Atlanta classification categorizes this as mild, moderately severe, or severe. So mild acute pancreatitis has no organ failure and no local or systemic complications. Moderately severe has transient organ failure, by which I mean less than 48 hours, and or local complications such as a pseudocyst or necrosis. Severe acute pancreatitis has persistent organ failure lasting more than 48 hours, often involving respiratory, renal, or cardiovascular systems. Now, many of the specialists that I talk to feel that clinical scoring systems for either the severity or the prognosis of acute pancreatitis are best avoided, as they provide little additional information and can delay appropriate management. And such scoring systems typically do require 48 hours to pass before they're accurate, by which time the severe disease will become clinically obvious regardless of the score. Now, these can include Ranson's criteria, which uses multiple laboratory values both at admission and 48 hours later, and the Apache 2 score, which is used especially in ICU settings. Now, it's important to say there is no specific pharmacological treatment for acute pancreatitis. The management of it is primarily supportive, and there are 4 key threads to this: fluids, pain management, nutrition, and antibiotics. So early, aggressive, intravenous hydration using lactated Ringer's solution is the cornerstone of therapy, particularly in the first 24 to 48 hours, because this helps maintain pancreatic microcirculation and reduce the likelihood of necrosis. With pain, then analgesia with intravenous opioids such as morphine is effective, and these should not be withheld due to any concerns about spasm of the sphincter of Oddi. With nutrition, early enteral nutrition is now preferred over total parenteral nutrition, so if patients can't tolerate oral intake, then nasogastric or nasojejunal feeding should be initiated within 72 hours. And routine prophylactic antibiotics are not recommended, even in cases of sterile necrosis. Intravenous antibiotics are used only if infected necrosis is either suspected or confirmed. An ERCP procedure is indicated urgently if acute pancreatitis is associated with cholangitis or persistent biliary obstruction, and we should suspect this based on Charcot's triad of jaundice, fever and rigors, and right upper quadrant pain. Cholecystectomy should be performed during the same admission for patients with gallstone pancreatitis to prevent recurrence, but in severe gallstone pancreatitis, cholecystectomy is usually delayed for at least 6 weeks until all the local inflammation has resolved. Drainage or debridement of necrosis is delayed until at least 4 weeks when the necrosis has become walled off, unless the patient has become unstable due to infected necrosis. Now, local complications include pancreatic pseudocysts, which are fluid collections without an epithelial lining that often occur after 4 weeks, pancreatic necrosis, which can become infected, and pancreatic abscesses and hemorrhagic pancreatitis, which are late, serious complications. Systemic complications include acute respiratory distress syndrome, acute kidney injury, hypocalcemia, hyperglycemia, and sepsis, particularly in infected necrosis. Now, despite having stated all those serious complications, fortunately for us, the majority of patients, about 80%, with acute pancreatitis tend to have mild disease and will improve within 3 to 7 days of conservative management. The overall mortality rate is about 5%, but in severe acute pancreatitis with infected necrosis or persistent organ failure, this may reach 30% or even slightly higher. And any pattern of deaths here is typically biphasic, with mortality in the first fortnight being related to systemic inflammatory response syndrome and multi-organ failure. But deaths after 2 weeks are due to local complications such as infected necrosis and pseudocysts. Recurrent episodes may lead to chronic pancreatitis and diabetes due to progressive gland destruction. Now, if we look at prevention finally, the most important aspect here is patient education. Eating a healthy, balanced, low-fat diet, maintaining healthy lipid levels, and decreasing alcohol intake significantly, preferably to 0, can help reduce the incidence of recurrent acute pancreatitis. And what's sometimes forgotten is there's also now significant data correlating cigarette smoking and recurrent acute pancreatitis. So all our patients who have had pancreatitis should also be strongly encouraged to abstain completely from any tobacco use. So I hope you found this podcast on acute pancreatitis helpful, but do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Feel free to get in touch via social media at GPnotebook or email support@GPnotebook.com if you have any questions, comments, or ideas for future podcasts. We really do love to hear from you. You should also visit us at GPnotebook.com to register for our virtual GP Notebook study groups and to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening and goodbye.